Yesterday, one of the speakers thought that he had 300 minutes and was disappointed to find he only had 30. I think that I could easily use 300 minutes to try and convey what I'd like to here, but having been one of the people who planned and structured this conference, I guess I have to sleep in the bed that I helped make. This is a treatment talk, but I first parenthetically want to say something about diagnosis. When I first started treating fibromyalgia and chronic fatigue syndrome, I would get referrals from physicians who were seeing these as manifestations of depression or somatoform disorder. Hopefully, yesterday, in listening to the very broad array and quality research that is going on in an attempt to establish the pathophysiology of these two illnesses, we can put this misperception to rest. Psychology shares with medicine the dilemma that without an established pathophysiology for these illnesses, that we're left to treat the symptoms. Yesterday there were references to the pervasive question about whether we have one illness or two illnesses here. I'm not going to weigh in on that in this talk, but certainly we have overlapping symptoms. Nevertheless, the symptoms appear differently in chronic fatigue syndrome and fibromyalgia, and so I'd like to talk about the treatment of the two illnesses individually. Of course, whether you're treating one or the other or a combination of the two, the first thing to consider is treating comorbid conditions. And while depression does not cause either of these illnesses, the incidence is higher than in the general population or other illnesses. And anxiety is a significant factor, if not at the clinical level, sometimes at the subclinical levels. We, of course, need to be alert for sleep disorders, if that may have been missed previously, and the arousal disorders that were spoken of yesterday are often a factor. Before talking about treatment per se, I'd like to talk just very briefly about the patient's experience of their illness. Psychology has found that a theory of stage or development is useful in understanding a variety of psychological experiences, and this is certainly true with illness. So we've identified 3 or 4 stages that people with severe and chronic illnesses tend to pass through. My practice encompasses treating people with everything from cancer to multiple sclerosis, as well as chronic fatigue syndrome and fibromyalgia, and I find that understanding illness in terms of a development of experience across time is very useful. People, particularly with sudden onset chronic fatigue syndrome, are oftentimes in a sense of crisis, in the sense that their life has just been turned upside down, and at that point they're kind of in a state of shock, and confused and not really able to take advice or instruction and use it constructively. Oftentimes this is mistaken as resistance. But as a person starts to adjust to the fact that their illness, that they have an illness, they can become more participatory in treatment, although in the second phase, which might be characterized as stabilization, there is still a low tolerance for the concept of chronicity and the prospective future for the illness. But the process of coming to accept their illness and finding an active role in it allows them to become more participatory in the healing process. And for some people who are able to treat illness as one of life's challenges that we don't get to choose, but nevertheless, if we can play the cards that we're dealt, we'll sometimes be able to develop an expanded sense of self and improve relationships and develop a meaningful life within the context of the illness. So in treating CFS, the psychologist sees many of the same symptoms that are diagnostic, and perhaps the hallmark quality is the cyclical pattern of improvement and crashing. I think that this is the factor that mental health professionals can be most effective in helping to treat. I'll talk about that in a few minutes. Sleep disturbances, of course, may reflect a sleep disorder, but it oftentimes also includes poor sleep hygiene. And the apparent exercise intolerance that characterizes CFS is an important area because pacing is a difficult thing for the patient to achieve in ways that I'll explain in a few minutes. The neurocognitive impairment that comes with CFS is, for some patients, actually more troublesome than the fatigue itself. The difficulties with concentration, recall, the notorious brain fog that people experience can be the cause of considerable despair. And finally, people with CFS tend to actually have different patterns of stressors, and those need to be looked at carefully. Verkulen and his research team applied structural equation modeling to look at the perpetuating factors for CFS and identified three factors: a lower sense of control, focusing on bodily sensations and reduced physical activity as accounting for the primary variance in the fatigue and functional impairment experienced by the CFS patients. Indirectly, an emphasis on somatic attributions contributed as well. Their study did not include depression, even though it was one of the factors that was analyzed. Clinically, however, I think that that is an essential perpetuating factor, and Dr. Lapp, who spoke yesterday, has said both publicly and in conversations with myself that he thinks that you cannot attain significant improvement with CFS without having successful treatment of the depression. The other perpetuating factors are also important and part of an overall treatment plan. So how do we go about doing this? Well, the research oftentimes focuses on cognitive behavioral therapy. However, the research outcomes are mixed. I think that that's because changing the thinking of the patient and developing skills are necessary but not sufficient. There's much of what I do in working with CFS patients that comes down to the influence of emotions in one way or another, the process of processing and adjusting to the way in which their lives have been turned upside down, and their capacity for activity and achievement being dramatically reduced is something that brings grief or anger or resistance, but needs to be worked through. Sometimes when I see people later in the course of the illness, they'll have already gone into a fairly deep depression for their inability to emotionally process the experience, and that then becomes the starting point for therapy. Reduced activity does not equate with rest and deep relaxation. I have patients who have had to quit their work, and they think that because they're sitting at home all day that they have reduced their activity. In fact, they may have actually experienced severe deconditioning, and yet they are not getting effective rest. Their worries and pressures, their emotional factors cause a continued level of autonomic arousal, and the person can be sitting in a chair all day, anxious and worried, and not getting the kind of deep rest that's restorative. Finally, CBT does not tend to address the existential factors that are important here. If you've had an important and meaningful work life, family life, and that has been taken away from you, the despair of loss of meaning and satisfaction and pleasure can be paramount. So working from a broader framework than cognitive behavioral therapy certainly shares with CBT the axiomatic starting point that changing cognitive patterns will produce behavior change, but then going beyond that, we're focused on treating the psychological distress, not considering it a rational process, but a process that exists outside of rationality. And the process of helping a person become more emotionally intelligent allows them to understand and benefit from their emotions in a way that oftentimes potentiates other important changes. We focus almost in every session on trying to control the activities that exacerbate symptoms, and this is a process of awareness training. People tend to be under-aware of how particular activities result in consequences, and much of the work that I do with chronic fatigue syndrome is a process of enhancing awareness and training attention. So working with pacing is one of the places where I think the mental health professional can be most effective. The physician can describe what would be appropriate, but we're a competitive culture of overachievers, and when we start to do something, we tend to really do it thoroughly. I sometimes have to handcuff, tie, and sit on my clients in order to slow them down enough so that they can really appreciate the very, very slow process of regaining and building activity. Talking about fibromyalgia has certain areas of overlap, but also differences. The epidemiological studies show that there's a very high incidence of childhood or adult trauma with fibromyalgia. That was alluded to yesterday, and so trauma work is often an important part of treating fibromyalgia. Depression and anxiety are highly prevalent and oftentimes may characterize the early stages of treatment. With fibromyalgia, the pain is, the fatigue is often attributable to pain in a way that is less clearly attributable to any particular etiology in CFS. And so treating the pain oftentimes is a 2-for-1 benefit in fibromyalgia. The perpetuating factors are somewhat similar but also different than with CFS. And the treatment strategies for fibromyalgia I think have to focus centrally on reducing the activities that exacerbate symptoms, which is more difficult than it sounds. We heard yesterday that fibromyalgia patients with that pattern of autonomic arousal are oftentimes high achievers, extremely competent, have a high sense of responsibility, tend to overdo and do things well, and it's not enough to tell them you shouldn't be doing this. You can even describe patterns that would be more healthy, and they're not likely to be able to adjust because their whole motivational system and sense of identity is very much tied up with their patterns of behavior. And so to try and affect the autonomic arousal patterns with fibromyalgia actually amounts to practically a personality overhaul. Finally, the attaining an effective relaxation and awareness training for people with fibromyalgia can be done pharmacologically, as was described, but the psychologist has tools that can be very effective. Hypnosis and guided imagery are helpful. but the literature and clinical experience confirms that meditation is the most effective and is highly effective. Trying to help a fibromyalgia patient develop an effective stretching program is oftentimes a psychological challenge in the way that I mentioned a few minutes ago. There's some support in the literature for aerobic conditioning, but that usually occurs after a lot of time and energy spent looking at the deconditioning and the ability to pace themselves. Well, coming back to where these two illnesses meet, hopefully in the brief overview that I've given you, that you've gotten a sense that mental health is attempting something more than just the treatment of depression. One of the important things I think that can happen with psychotherapy is the potentiation of the work of other healthcare providers. So compliance with pharmacological interventions and an effective use of structured exercise treatments is more likely when there's adequate support and reality testing provided in greater depth than can happen sometimes in the physician's office. Group psychotherapy has tremendous potential for both of these illnesses. A few years ago, I collaborated with a rheumatologist, and he co-facilitated psychotherapy groups with me. We were running 3 groups that ran for 2 years each. He referred all of his high utilizers and resistant clients to the groups, and after the first year found that his high utilizers were scheduling no more often than his arthritis patients. I think this is because people were able to feel less isolated, to take advantage of learning from their peers, people who were suffering in the same way, and for the opportunity to look at the emotional drivers that constitute the motivation to perpetuate maladaptive behaviors. I just want to put a plug in for what healthcare providers in general can offer in a psychological fashion. Empathy and caring are themselves curative. Research in medicine tends not to look at this. We focus on it in psychology quite a bit. I think medical research kind of lumps this into the placebo condition. But sometimes the medical health care providers can accomplish as much with the words you use as the prescriptions that you write. Fibromyalgia and chronic fatigue patients are oftentimes the bane of physicians' practice, in part because they're high utilizers, but oftentimes because they're perceived as being resistant. The resistant patient is simply too afraid, uninformed, or attached to an idea to change. If you can understand what it is that's going on for that person in terms of their thinking and their emotions, you've turned the corner, and you'll find that the person is much more ready to be an active agent in their own treatment, but that psychological corner has to be turned first. Finally, when CFS or fibromyalgia patients start to improve is the time for caution, because people have been facing limitations and missed important parts of their life, and as soon as they start feeling better, want to make up for lost time. So the cycling pattern of improvement and crashing that is so distinctive in CFS appears in a more muted form with fibromyalgia, and helping people to recognize that pattern and anticipate it, I think, is very important. Yesterday was very exciting for me, as is the conferences that I've been attending for the past few years, because the research is just getting more and more focused. We're discovering the convergence of these fields, and I think that the result is not only going to be that at some point we'll establish a pathophysiology for these two illnesses, but that it will also provide for more targeted psychological interventions. 10 years ago, when the importance of autonomic arousal was less understood and talked about, it was typically less a part of psychological treatment, and I think that that's changed considerably in the last few years. And I'll just close by saying that the reason that I find it so meaningful to work with CFS and fibromyalgia patients is that when we lose our health, it can be so traumatic that it requires major self-examination on the person's part. Not everybody is able to do that, but for people who rise to the challenge, that there's an opportunity to discover a greater depth and breadth to oneself, and that people can actually use the challenge of illness to develop a heightened sense of meaning and richer personal relationships. So where we can't cure people of these illnesses, I think that there's tremendous potential to facilitate healing. Thank you.